through MixApp 19, question 44. Last thing, this is definitely advanced. To think about adding on for these patients or subsequent management for more advanced management of these patients is going to be lung reduction surgery. To decrease mortality and to get really good response with patients, there's a lot of patient selection that you need to manage. And the patient selection that you're really going to need to manage here is going to be, choosing patients that specifically have upper lobe emphysema, choosing patients that really have poor exertional capacity, and to decrease mortality from surgery. I'm not sure if this decreases mortality of surgery or you're not selecting people who have such little lung function less that you can't remove any. You want to make sure that the patient has a good FEV1 and a DLCO that are both greater than 20%. If it's less than 20%, they have increased mortality from this procedure, and you don't want to do lung reduction surgery on these patients. So why does lung reduction surgery work? So here's a patient with more predominantly upper lobe emphysema. So you're cutting out, let's say, these parts of the lung here. And what that does is allow the good part of the lung here to expand and fill up the rest of the chest wall. So the good part of the lungs that has pretty good oxygen and CO2 diffusion is now more open to get more air into it. And you also have your breathing is going to be a little bit more efficient. Reason why? Because you reduce that hyperinflation. So when you get hyperinflation, your diaphragm gets very flat. When your diaphragm gets very flat and when it contracts, it really can't move too much air in. So if you reduce that and you get a little bit better curvature of your diaphragm by bringing that good lung up, you're going to get better efficiency of the diaphragm, and when it contracts, it's going to be able to bring more air into the lungs, reducing the efficiency of breathing. But remember, you really need good selection of these patients. So upper lobe emphysema predominantly, poor exertional capacity, and then FEV1 and DLCO is greater than 20%. If you do find a patient like that, with lung reduction surgery can be very, very helpful. All right, to this question, pulmonary question 64. So this one is getting really into treatment of COPD exacerbations. So really going through the pathophysiology of COPD exacerbations, I'm not sure how true this is, but I thought that 1/3 is maybe bacteria, 1/3 can be viruses, and 1/3 can be pollutants. These things come together to make inflammation of the airway, and then inflammation of the airway can not only increase systemic inflammation, so patients not only from the smoking, but from COPD itself, they can get, or really any inflammatory disease can get increased risk of endothelial damage and atherosclerosis, but they'll also get edema, mucus, bronchoconstriction, which can lead to these exacerbations, wheezing, cough, shortness of breath, dyspnea that you say. So how do we treat it? You really want to hit this on multiple levels. So for infection-wise, any inpatient, you should just automatically treat for infection. We'll get into the antibiotics soon. Outpatients, you really want to pick the patient population that may have a subsequent increased risk of having a bacterial infection causing their COPD exacerbation. So things that we look at, they need 2 out of 3, increased dyspnea, increased sputum volume, or increased sputum purulence. So increased dyspnea or increased quantity or quality really of their sputum. Make sure you test for flu, and if it's flu season, if they had quick onset of fevers, chills, myalgia, arthralgias, oseltamivir works best when it started early. So consider empirically before you get tested back. If testing's going to take a little bit. Lastly is what antibiotics do you use empirically, and this kind of depends. It's not going to be, I don't think, asked too much on MixApp. I'm kind of going by our own guidelines. So for outpatients or inpatients with mild exacerbations, you can really go with azithromycin. It should be fine. Azithromycin has not only antibacterial effects, but also the anti-inflammatory effects, so it can be very, very helpful. If the patient, let's say, has an inpatient severe exacerbation, it's shown that a lot of severe exacerbations are caused by typical bacteria, and a lot of typical bacteria like Strep pneumo, H. flu, Varicella may be resistant to azithromycin. So these patients, you might want to consider augmentin or ceftriaxone. Lastly, and something that's commonly missed, because I think most people would just say, okay, COPD exacerbation, let's start the patient on azithromycin. If the patient has a higher pseudomonal risk, you really want to do an antibiotic that treats for Pseudomonas. In our hospital, we use cefepime as our antibiogram. Shows that cefepime has pretty good coverage of the Pseudomonas in our area. So things that might put you at high pseudomonal risk, it's kind of similar to when you cover it for CAP. So if they've had antibiotics in the last 90 days, especially broad spectrum on hospitalization, if they have severe recurrent COPD exacerbation, use of steroids, if they've had Pseudomonas in the past and they have gram negatives or Pseudomonas on their sputum, obviously, or if they also have a history of concurrent bronchiectasis, which we'll get to in a little bit, those patients are at high risk for Pseudomonas as well. Another one to think about for patients with COPD is that once their FEV1 gets less than 30, not only do they have increased mortality from COPD, they actually have a change in their microbiome in their lungs, and they have increased susceptibility to resistant organisms, including Pseudomonas. So if they have that increased Pseudomonas risk, really consider starting those patients instead of azithromycin on cefepime, especially if you have a higher risk patient who's severe, hospitalized in the ICU. If Pseudomonas could be the cause of that, you really want to eradicate it. Secondly is treat that inflammation. Use prednisone. You do 40 milligrams for 5 days based on the Reducer trial routinely. And then lastly, treat that bronchoconstriction. Do NEBS, but you only don't want to do it Q4 to Q6. This is muscarinic antagonist, so you do it too much longer than that, patients can do too more frequent than that, patients can get anticholinergic side effects. So they might have urinary retention, they might get hot, or they might have constipation. So that urinary retention and constipation, you don't want to give them muscarinic toxicity, antimuscarinic toxicity. So you want to limit that Q4 to Q6, but you can do albuterol more often on top of that. All right, do this question. All right, so this one gets into cystic fibrosis. So the hardest thing about cystic fibrosis is testing for it. There can be sometimes delayed penetrance, so patients may not present with cystic fibrosis later in life. Not uncommon, but does happen. So usually it's more in the realm of pediatrics, but sometimes it's in the realm of internal medicine as well. So okay, let's go into the pathophysiology of cystic fibrosis, right? So what happens? So there's the CFTR, which really is a chloride channel. So normally chloride is able to, so here's the intracellular space, here is the extracellular space here. Usually chloride can go outside this chloride channel. Boom. It goes in the extracellular space like an exocrine duct or sweat outside the sweat glands. And then what happens with it is that sodium, and with sodium, water follows, which makes your secretions less viscous. And chloride is a very important component of that. So let's say people with have a mutation in that CFTR, the chloride is not able to exit the cell, can't get out, which means water, sodium, and H2O are not able to follow. What that does is make your mucus extremely viscous, extremely thick. So you get really thick, viscous mucus, and that is the reason why you get a lot of the clinical manifestations. So one thing you kind of get is going to be bronchiectasis. So this is one of the main morbidity and mortality in patients with cystic fibrosis and a lot of times that we treat. So there is the vicious cycle hypothesis for bronchiectasis, and all bronchiectasis with cystic fibrosis being one. So mucociliary clearance is decreased, and this is what happens with cystic fibrosis. If they have thick mucus, so they have decreased mucociliary clearance. That increases your risk for infections. And in cystic fibrosis, these patients can get a lot of infections. Most commonly Pseudomonas, as it has biofilm formation, it can kind of stick around chronically in the lungs, but sometimes they can get MRSA, nasty things like stenotrophomosis, Acinetobacter. So they have a really increased risk for infections. Those infections give you bronchial damage, and that bronchial damage subsequently gives you bronchial dilation. And when those bronchial dilates, not only can they create obstruction, so you can see that with PFDs, from dilation of really flimsy airways that can subsequently collapse, that also can go decrease your mucociliary clearance, kind of starting this vicious cycle all over again. Things that you look on exam would be the signet ring sign. So what is the signet ring sign? So here is going to be your arterial, here is your bronchi. Your bronchi dilate, and they actually become bigger than your arterioles. Also, because that area of the lung may get hypoxic vasoconstriction, your arterioles may be a little bit small, and this looks like a ring. So that would be called your signet ring sign, which you see here in a couple of different places. These patients can get progressive worsening lung function, worsening recurrent infections, and increased mortality secondary to this. So that's your pulmonary manifestations. Next is going to be your GI. So things that can be affected by that viscous exocrine secretion is that you can get problems with the pancreas. The pancreas can get viscous excretions. It can get blocked. So you can get pancreatitis, and sometimes you would work up, in certain cases, cystic fibrosis and chronic pancreatitis from just blockage of the pancreas and release of pancreatic enzymes into the pancreas. But the other thing that happens is that you can't secrete things like lipase, tryptase. So specifically, you can't break down bile acids. So your bile acids get stuck in your intestines. They can do a couple things, right? They can bind calcium, which leads oxalate to himself to be reabsorbed, which can cause nephrolithiasis. The bile acids and fat absorption is need for absorption of vitamins, so you can get vitamin deficiencies. A, D, K are the fat soluble ones, so that can happen. It can also affect your biliary tract. You get viscous biliary secretions which subsequently blocked. Patients can get cirrhosis from chronic blockage of the biliary tract and subsequent back pressure. And even in some cases, because you don't have bile acid reabsorption, the liver creates more bile acids that can supersaturate the gallbladder, giving you gallstones. Lastly, secondary to absence of vas deferens in some cases, these patients can get infertility too. So how do you make the diagnosis? Well, you really want to do a chloride sweat test. First line. Now, it's a little bit weird. In the skin, chloride has a decreased ability actually to move from the extracellular space back intracellularly. So that actually, coincidentally, the chloride in the skin is going to be high. So you get high chloride. If that's negative, but you still have increased suspicion, to refer these patients, they may need genetics and testing for the CFTR gene mutation. Or another thing that they can do is a nasal potential difference. And the NPD looks at the charge within cells, I guess mucus cells within the nose. They should be more negative because there's more chloride inside of them. So that nasal potential difference could be kind of like a second line test. But first line is really going to be that chloride sweat test if you have a suspicion. Lastly is going to be treatment. So treatment is really going to be focused on breaking up this thick mucus. So what kind of things can we do for treatment? One is some clearance techniques. So things that can help break up this mucus is going to be chest physical therapy, kind of beating on the back of the chest. There's certain thumping machines that are oscillate and break up that thick mucus as well. Exercise and actually having the patient cough pretty frequently. So forced cough could be other clearance techniques that really just work to mechanically break up this thick mucus. Two, especially in the lungs. I'm mostly talking about the lungs here. Hypertonic saline. So getting that sodium right into that thick mucus is going to bring water in. That's going to break it up. This one's a little bit interesting, but these patients can get neutrophils in that thick mucus with inflammation. Those neutrophils will have DNA, and that DNA can break down. And that DNA breaks down, it actually makes when that DNA breaks down, it actually makes the mucus secretions more severe. So there's a medicine that kind of cleans that up. It's called dornase alpha. That causes breakdown of that DNA, which makes the mucus less thick. And then lastly, sometimes we'll get maybe into this a little bit more later in the lecture, but these patients get chronic infections, especially Pseudomonas, due to biofilm formation of Pseudomonas and chronic infection of the lungs. So you may need to consider long-term antibiotics for these patients too, especially if they have frequent exacerbations. Lastly, how can I forget? These are really newer meds, and really sounds like they've changed treatment hugely and changed subsequent prognosis of patients with cystic fibrosis could be CFTR potentiators. So these actually work on the mechanism of that decreased functionality of CFTR, the chloride channel gene. So the medications used here, we usually actually combination, so it's called ETI. Put your names with like Efcator, a bunch of things with a first part and Caftor at the end. These are all CFTR potentiators, and usually you give them as a combo drug, which we call in short-term ETI. So that's all your treatment. This is a little crazy, but that's all your treatment, diagnosis and treatment of patients with cystic fibrosis. All right, to this question, I think we have two more. All right, so we went over this a little bit. So pathophysiology of, so this will be a little bit of review of patients with bronchiectasis is going to be that vicious cycle hypothesis. So remember, these patients get bronchial damage, which leads to dilation, which leads to decreased mucociliary clearance, which and then subsequently leads to further infections, causing dilation of the bronchi. So there is a lot of different causes of bronchiectasis, and I like to use this general pathophysiology of this vicious cycle hypothesis to explain what things can cause and what things you always work out for when you see someone with bronchiectasis for the first time. So first one, you want to look for infections, right? So does this patient have a chronic infection causing that vicious cycle, right? So there can be a lot of different ones. A lot of times the infection could be TB. So mostly non-TB mycobacteria. So MAC might be more common in an older lady. Maybe she has middle lobe bronchiectasis. Like we used to call it Lady Windermere syndrome, where they thought, I don't know if this is true, and probably not, but they didn't cough, and that would lead to subsequent MAC infection of their airways, and subsequently they'll get more middle lobe bronchiectasis. So definitely something to look for. Other other bacteria that can cause it would be nocardia, fungal can cause it. Specifically, one that can cause an asthmatic, so we would call this an asthma plus syndrome, would be allergic bronchopulmonary aspergillosis. So that chronic pulmonary infection with aspergillosis, which is worsened by chronic steroids, can cause bronchiectasis from a chronic infection and cause airway damage and subsequently very difficult to control asthma. So all patients that have any diagnosis of bronchiectasis, you really want to check a sputum smear and a CBC with diff to look for eosinophilia, which could be present in ABPA, to work these things up. And kind of on the same thing here, immunodeficiency is going to increase your risk for chronic infections. So that's another thing you want to work up as well. Most commonly is going to be hypogammaglobulinemia from common variable immune deficiency disorder. To work that up, which can happen at any age. It can be acquired. It can happen in your 20s, 30s. You want to check immunoglobulin levels to make sure you screen for that. That could be a reason why this patient's getting recurrent infections. Neoplastic is going to be more decreasing that mucociliary clearance, and the reason why is by obstruction. So you can have focal bronchiectasis from a mass, which basically causes obstruction of that area, decreased mucociliary clearance, infection behind it, damage, dilation, subsequent focal bronchiectasis. So everyone needs, all patients, when you're concerned about bronchiectasis, need to HRCT, PFDs. If you do see a mass there, maybe you do a flex bronch and try to do a biopsy of it. Congenital, we went through a little bit, so cystic fibrosis. Small, I mentioned earlier, but a small amount of diagnosed after 18. It's some similar things as well, like primary ciliary dysfunction or alpha-1 antitrypsin can cause bronchiectasis. So our patients, bronchiectasis, check for sweat chloride. Consider second, if you have a high suspicion, consider secondary texts of CFTR gene analysis, maybe NPD. If you have increased suspicion, maybe have some liver disease as well. Maybe they have some evidence changes, check it out for one antitrypsin. And then lastly, it's going to be autoimmune. So most patients with these diseases are going to have chronic, really poor, these congenital causes mostly decrease the mucociliary clearance. So anyway, autoimmune causes, they're going to have long-term diseases, so it should be relatively apparent if they are bronchiectasis from bronchial damage from autoimmune disease. But if you don't, so you really only do it with increased suspicion for autoimmune disease. You might check for lupus, Sjogren's syndrome, and RA, which can sometimes cause bronchiectasis. Diagnosis, is going to require CT, so think that you're looking for CT. The one I talked about already is that bronchial alveolar ratio. So you can see it here. The arteriolar and the bronchi, which is very dilated. That's called your sigmoid side. But other things that could help you make the diagnosis is see this lack of tapering in the bronchi. So bronchi should get much more taper as they go out to the periphery. You don't see it there. So that's called tram-track appearance that you may see. That's going to be caused by bronchodilation. Or you can see airways visible within 1 millimeter of the pleura. 1 centimeter of the pleura. That's also abnormal. The airway should be very small out there. So if you can see them, they're very dilated. That's another sign of bronchiectasis. So this is how you make the diagnosis of bronchiectasis. Remember to get a high-res CT. You want to make thin cuts so you can really see the anatomy of the bronchi to see how dilated they are. And lastly is going to be the complications. So one of the complications we talked about is going to be chronic infections, Pseudomonas, MRSA, but usually it's going to be the thing you worry about is Pseudomonas. These patients may need inhaled Tobra. If they have a chronic infection with chronic exacerbations, get rid of that chronic Pseudomonas. And lastly, bronchiectasis is one of the most, I think it may have not been the biggest cause of actually pulmonary hemorrhage. So they can get erosion from that bronchial damage into an artery. That artery can cause hemoptysis. It can be massive, and then if it is massive, you need to really get pulmonary and IR on board, as well as maybe CT surgery, and you're going to need to really treat that as quickly as possible because massive hemoptysis can be very deadly. But one of the most common causes of massive hemoptysis, and what I've seen in the hospital, truthfully, is going to be bronchiectasis. All right, last question. So we went through this a little bit already when we went to cystic fibrosis, but this question gets into really chronic management of non-CF bronchiectasis and treatments of bronchiectasis flare. So chronic management of bronchiectasis, reduce the damage, right? So treat underlying disease. In cystic fibrosis, it's maybe with the CFTR potentiators. 2 is going to be increase mucus clearance. So you want to have techniques that really going to break up this mucus, right? So things you can do that would be like pulmonary, PT, oscillation devices, that kind of beetle in the chest. Hypertonic saline can be helpful. Exercise is really huge, and making sure they do exercise that actually helps with clearance, and then forced cough. All things that can really help for these patients. Lastly is pulmonary rehab, similar reason for like COPD patients have greater than mild symptoms. And our last thing here is going to be chronic antibiotics. So we talked about this already, 2 to 3 exacerbations of yield to inhaled Tobra. If Pseudomonas, consider macrolide. If not, and now treatment of bronchiectasis flare. So usually, if bronchiectasis flare is going to be a buildup of any of the bacteria that aren't cleared, causing worsening dyspnea, worsening cough, sputum production. right? So outpatient, you can consider Cipro empirically. The reason why you want to use Cipro is it has some pseudomodal activity, with pseudomonas being a very common pathogen that causes due to biofilm formation. You can use augmentin, but only if your sensitivities are known and the patient doesn't have pseudomonas. Empiric inpatient management. So remember, pseudomonas is the most common. If they have a mild bronchiectasis exacerbation, you can think about pseudomodal monotherapy, but if it's really getting more moderate severe, you want to cover your bases. You want to cover MRSA, and you also want to do double pseudomodal coverage, would be something like 17 plus ciprofloxacin, just in case one of the therapies that you pick that the specific pseudomonas pathogen in their lungs resistant to. Honestly, look at their old and really look at all their old sputum cultures if you ever think about empiric inpatient management, and treat for whatever the most resistant one is. There can be some really, really nasty bugs, Acinetobacter, Burkholderia, things that are really, really drug resistant. So you actually might have to think, definitely get an ID consult, but you may really have to think about even some of your more advanced antibiotic therapies that are more advanced with even Zosyn and cefepime to cover things like carbapenemase resistant Enterobacter or things like Acinetobacter as well. So really look at those all their previous sputums and cover for the most resistant pathogen you can find. Also, obviously, get ID and maybe talk to your antibiotic pharmacist to consider what pathogen to use in these patients, because they can have really chronic infections with really highly resistant organisms. All right, so that's our review. Just for anyone watching, I'll put these at the end so you can patch through and just take a look at the slides. But here's our slide on approach to COPD. Think about this when you have someone that has a history of COPD but never had PFTs. These are things to ask the patient, do physical exam of the previous imaging to increase or decrease your suspicion of chronic COPD, which may help subsequent outpatient and inpatient management. But obviously everyone needs PFTs. Treatment of COPD by Gold Group. Here, remember that everyone's going to get a SAVA, PRN, and really a LAMA maintenance therapy as well. More symptomatic, you're going to add that LAMA therapy, and once you have more high risk with recurrent exacerbations, you're going to add ICS therapy as well, but look for that laboratory mark of inflammation with those eosinophil counts or features of asthma COPD overlap. Adult management for all patients, pulmonary rehab, flu, stop smoking, check alpha-1 levels, see if they need chronic O2 therapy, if they have frequent exacerbations, if they have severe COPD, think about roflumilast and macrolides, then upper lobe emphysema, poor exertional capacity, FEV1, DLCO, think about lung reduction, surgery. Treatment of COPD exacerbation, inpatient, always treat for infection, outpatient. You really need two of those three characteristics. Azithromycin is going to be your main workhorse for patients with outpatient exacerbations or mild inpatient exacerbations. If it's severe, though, you might want to think about better coverage of your typical organisms with augmentin or ceftriaxone. And always make sure you see if the patient has pseudomodal risk as well. Really low FEV1, history of pseudomonas, recent antibiotic use, recent hospitalization, recurrent frequent exacerbations, concomitant bronchiectasis. Everyone gets oral prednisone as well. 5 days is routine, and then treat their bronchoconstriction with something like Duonets, Q4-6, and albuterol more often. And then cystic fibrosis pathogenesis. It's really that abnormal cystic fibrosis chance membrane regulator gene, which decreases the amount of chloride in the extracellular space, giving you thick mucus. That thick mucus can give you bronchiectasis, can give you pancreatic enzyme malfunction with bile acid malabsorption, diarrhea, vitamin deficiencies, increased risk for nephrolithiasis, and even increased risk of cirrhosis, secondary biliary obstruction, and can give you an absent vas deferens. For diagnosis, do that chloride sweat test. If that's negative and you don't have a high suspicion, consider genetics and then do testing. And then treatment, things to really break up that mucus. It can be stuff like Dornase alpha to breakup of the DNA, which can subsequently thicken the mucus. Consider chronic antibiotics, chronic inhaled antibiotics. You'll do tobramycin if they have a history of pseudomonal infections. Macrolides you can do orally chronically if they don't have pseudomonas, but it's more for the anti-inflammatory effects. Mucus clearance techniques, which we reviewed a couple times now, and specifically for cystic fibrosis, you can think about the CFTR potentiators, ETI, which is that combo drug for all the three potentiators that can really help these patients get that chloride from the intracellular space, the extracellular space, and really help with mucus secretion. I'm not going to go over this too much, but remember your vicious cycle hypothesis of mucociliary clear infection, bronchial injury, and bronchial wall destruction. And remember to work up for all the causes of bronchiectasis when you first get it. So you can think about working up for infection. Could they have a chronic infection, a chronic atypical infection or immune deficiency that puts them at risk of the infection? Check a sputum smear for everyone, CBC with diff and immunoglobulin levels. Everyone gets HRCT and PFTs no matter what. If you see some sort of obstruction, maybe there's a mass of a neoplasm, maybe a bronch. Congenitally, always check for sweat chloride. 7% of patients with cystic fibrosis are diagnosed after 18, so it doesn't mean they don't necessarily have it, but an alpha-1 antitrypsin with suspicion. Autoimmune can do it from causing autoimmune-based bronchial injury as well, but those patients should have other systemic manifestations of their autoimmune disease. Diagnosis of bronchiectasis kind of showed here on our high-res CT. I'd always get high-res CT, not just the regular CT, to see really good outline of your bronchioles and bronchi to make the diagnosis, and then complications. Think about that chronic infection risk, and these patients can get hemoptysis, which can be sometimes massive and deadly. And last one is here. So this is kind of goes over all of your treatment of non-CF bronchiectasis and your treatment of the bronchiectasis flare. Outpatient is Cipro empirically, but inpatient, look at their previous sputums and go from there. If it's mild, they don't have any previous sputums, think about pseudomonal monotherapy. But if you really have severe severe bronchiectasis exacerbation, so patient with bronchiectasis coming in, you don't see a infiltrate, so you don't think they have pneumonia, but maybe they have worsening dyspnea, cough, sputum reduction, wheezing. Those patients, pseudomonal monotherapy, if mild, and no previous micro, and if it's severe, really severe or even moderate exacerbation, get first and double pseudomonal coverage, and that's it.